Well, welcome everyone, and thank you so much for joining today's Connect and Explore webinar. I am Elaine Arkin, as you just heard, with the Coordinating Center for the National Collaborative on Childhood Obesity Research, or NCCOR. I'll be moderating today's webinar. Today's program, let me just move this. Okay, today's program will feature a spotlight segment on the complicated relationship between childhood obesity declines and disparities. The second half will look at tackling inequities by rethinking intervention and policy design. And then, after this main feature, we'll have a one-on-one segment, and this is where you can ask our presenters questions. And then finally, we'll talk a little bit about what's next for NCCOR and when it comes to exploring research and efforts in this arena. Now, just a note before we start, if you have a question for our speakers at any time during the presentation, please write it in the chat box on the left side of your screen. Also, if you need technical assistance during today's webinar, please let us know using the same chat box. If you're having trouble logging into the webinar but can hear us on the phone, please email us at NCCOR, that's NCCOR, at FHI360.org, NCCOR at FHI360.org, and we'll work with you to resolve the problem and get you on the webinar. Finally, one more important note. If you've decided to listen to our webinar today using your computer speakers, please turn down or mute your computer microphone. This will greatly reduce the potential for background noise. There are a lot of us on this webinar. We're delighted to have you all, but it means that the chance for noise is higher than usual. Now, we'll also be live tweeting during today's webinar. If you're on Twitter or other social media, we urge you to join the conversation by using the hashtag ConnectExplore and following the Twitter handle at NCCOR. Our speakers today are Dr. Shiriki Kumanyika and Tim Lobstein. Sorry, Tim. Shiriki is the Emeritus Professor of Epidemiology at the University of Pennsylvania Perelman School of Medicine. She's also the chair of AACORN, the African American Collaborative Obesity Research Network, and the current president of the American Public Health Association. Welcome, Shiriki. Tim is the Director of Policy at the World Obesity Federation, and he's joining us today from London. Tim, thanks so much for accommodating the time of our webinar and graciously joining us. You'll have a good audience in the States today. Now, before we get started, we'd like to just stop for 1 minute and open with a brief poll, one question. To the left of your screen, above your name, you'll notice a button with the letter A in it. It's just like the one shown here. Please move your cursor over this button and you'll see a drop down, and then you can click to select your response. Just give you a minute to see that. I'm hoping that you're finding the box with the A, B, and C. And then if you click down, this is the question. How familiar are you with childhood obesity declines and disparities research? Are you very familiar, somewhat familiar, or not familiar? Now we'll just stop for a minute and give everyone a chance to try this out. I know that a few of you are still answering, but we have most people here. And as you can see, thank you, Jordan, that just about half of you are somewhat familiar with childhood obesity declines and disparities research. So that gives us a good idea of who's on the phone with us. And we hope that at the end of this, you'll be able to move your response up closer to A. So thank you so much, everyone, for joining our little poll. And now I'd like to turn it over to Shiriki for our spotlight segment on childhood obesity declines and disparities. Shiriki?
Thanks, Elaine. As you've heard, the topic of this webinar is related to the fact that the declines we've been seeing in obesity are not equally seen across different groups of children, different groups by racial, ethnic classification, or by socioeconomic status. In several cases, the disparities are actually increasing. So I'm going to start off by walking through what these trends look like, and then talk a little bit about why. So starting with 2 to 5-year-olds, this is with both sexes combined, you see 3 different patterns. The white children are now decreasing. It's purple and has the lowest prevalence. There are increases in black children, which is the blue line. The increasing in Mexican-American children, there seems to be some stabilization, but at higher levels. So overall, the gap between whites and the ethnic minority groups is increasing. Going into the 6 to 11-year age group, we have data that's separate for boys and girls. So in the boys, you see an increase and then a slight decline in the Mexican-American and white boys. So the orange and the purple lines are similar, but the Mexican-American boys are much, much higher. And then you see this increase in the black boys really beginning to exceed the level in the Mexican-American boys. So again, you have a wide gap that seems to be widening over time. In girls, 6 to 11, you see increases in the greatest increases really in the Hispanic girls. The black girls are higher. And again, the white girls have the lowest obesity prevalence, and it seems to be leveling off. Turning to adolescents, first with the boys, you see that they're all increasing at some level, but it's leveling off at lower levels in the white adolescent boys, and there's still the current trend of increase in Mexican American and black boys in that initial period, and then in the more recent trend. So we have wider gaps than in the initial part of the period. And for the adolescent girls, you see increases. It looks like these trends may be converging. There's a slightly decline in the black girls, so that's a promising trend. The white girls are increasing, and the Mexican-American girls have leveled off. So this is the one area where it doesn't look like the gaps are widening, and we have to ask ourselves, why are these trends so different in all these different groups? Let's go to socioeconomic status next, and this time it's the poverty line, so the blue line at the top where you see the increase are the children and families and households that are living below poverty. And the most well-off are in the green line at the bottom, families with 400% or more, 4 times or more the poverty line for those children. And so you see the widening gaps by income over time. If you compare the blue below poverty and the 4 times the poverty line, you can see how this gap has really become larger. 6 to 11 children, and then we go into the adolescents again, and we can see that the white children, same colors, different code. The most well-off children are the lowest, and the living below the poverty line or near the poverty line, the blue and the orange, you see either a recent or a steady increase in those children. So again, widening gaps. Now this becomes even more complicated if you break the socioeconomic status trends down by gender or by gender and race. And this is just an example from a CDC Health Disparities report. So obesity prevalence increased in girls where the head of household had not finished high school from 17 to 23%. But in girls whose head of household had completed college, it was lower to start with, 11%, and it decreased over the same period. There was no interaction like that seen in boys, so this relationship in girls was different from what was seen in boys. When you add the race ethnicity and you look at white boys versus boys and girls versus black boys and girls, it was found in this report that the white boys and girls, the college-educated parents, had the lowest levels of obesity. There was no association at all of the parents' education or the education of the head of household in the black boys. In the girls, there was an association, so that the girls in households where the parent had completed college had the lowest levels, but they didn't decrease over time, whereas a decrease over time had been seen in the white girls. So it's really a very mixed picture. So if you pull these trends together, you see notably higher obesity rates at most ages in the minority and lower income groups. It suggests that the current solutions are not closing the gaps. If we think that what we're doing is helping to decrease the rates in some of the population subgroups, then it's not reaching, they're not reaching all populations. The effects vary at the intersections of race, ethnicity, gender, and socioeconomic status, which suggests that there may even be clues within these groups about why some kids are responding and some are not in terms of improvement. So we have to ask ourselves, what do we know about the pathways that have implications for solutions, and how would we act on those solutions? So I'll turn to a slide that I think a lot of you might have seen before. It shows the 5 key principles and types of environments or settings for action to accelerate progress on obesity. If I start with food and beverage environments and go clockwise, we need to make healthy foods available everywhere. We need to activate employers and healthcare professionals to take actions to improve the environment through obesity. We need to integrate physical activity every day and every way across all different environments, use schools to the maximum, both during the school day and as community resources, and then surrounding all this are message environments that include commercial marketing and social marketing, and we need to market what matters for a healthy life, which means we have to change the ratio of messages so that the healthier messages really begin to exceed the less healthy messages, which is far from the case at the moment. The IOM committee that developed the strategies that were on the last slide recognized that all these environments and settings are not equivalent. In the middle of the slide, you see this quote from the IOM report. Social, political, and historical contexts influence the starting point, the opportunities, and the responses to changes in environments for physical activity and eating. These factors must be taken into account when considering inequities in obesity prevalence and trends by race, ethnicity, gender, socioeconomic status, and residential areas. So there's a challenge of achieving equity is to find these inequities in the environments, consider the factors that lead people to respond to these environments and to the interventions differently, and then see if we can fix it so that the children who are starting off with a more challenging environment actually can catch up and achieve healthy weights. So how do we do that? Well, we have to kind of go through a thought exercise about what is happening in different environments, and this is using a familiar breakdown of the physical, economic, and usually you see the social cultural environment. I'll mention that later, but I put the message environment here because we need to pay as much attention as possible to the message environment. So in the physical environment, the mix of available retail outlets and products is less favorable. There are visible outdoor ads promoting unhealthy food that are more common. In the economic environment, the first 3 factors listed relate to cost. It just costs more to buy healthy food, at least and healthy food people can eat in the time they have to prepare it. The foods that you can get at a bargain tend to be unhealthy. Then and at the individual, at the school level, if limited funds are available for school meals, the providers are going to start cutting corners in terms of the healthfulness of the food. And also in these data, the findings that these are particularly important for high-risk communities are based on data for African Americans, but they're more broadly relevant. That some resources and opportunities in Black communities, for example, are really closely linked to companies that sell unhealthy products, jobs, sponsorship, things that offer community benefit. In the message environment, there's heavier advertising of unhealthy foods, which is exacerbated by the fact that there's higher media use, and then further by the fact that when the advertising is not just more, but it's ethnically tailored, it's more salient to children who can recognize people like themselves in the ads. I'm just going to illustrate this point about deals and getting foods at lower cost. This is from a study we did. We analyzed thousands of transactions from some families who shopped in a particular supermarket over about a year's period. And where the arrow is pointing, the finding is that when the foods were on sale, people were more likely to buy them. So the odds of buying high-calorie foods when they were on sale were 2-to-1 overall for these foods, and then you see below that a 6-to-1 odds for sweet snacks, more than 6-to-1 odds for grain-based snacks, and 2.6-to-1 odds for sugar-sweetened beverages. And so when people were more likely to buy these foods when they were on sale versus when they were at the regular price, and if you just take a look above, that wasn't the case for the healthier foods that we looked at, possibly low-fat dairy, but that was marginally significant. So what's on sale matters, and if it's unhealthy, and people like it, they will buy more of it, or they'll wait for the sales to make sure they can afford it. We can go through the same thought exercise for the physical activity environment. So you can see things in the green that there are factors that discourage outdoor activity, which is critical to getting enough physical activity. Discourage or even constrain activity, especially for children where parents are worried about their children being safe, and where aesthetics make a difference in terms of whether people want to be outside. The economic factors are really diverse. There's cost of private gyms and things like that. There's the type of jobs people have. If they've been working on their feet all day, they might think they'd be crazy to come home and then go out and go jogging. The status associated with being sedentary is illustrated by the cars and the way cars are advertised and the reverence that people have for cars, and then the marketing of electronic media for entertainment. And the third box here in media, message environment for physical activity, I wanted to point out that we really haven't studied what that message environment is as much. We don't know how much that's contributing to the high risk in some groups. So the question marks indicate that these are things we should consider. Is there disproportionate promotion of a sedentary lifestyle, entertainment, or spectator sports in high-risk communities? And if so, what can we do about that? So this mentions the social cultural environment. On the left, for food and body image, and on the right side for weight. These are, again, data from Black Americans, but perhaps more broadly applicable. So we often think about this first. People think about ethnic differences and, well, it must be the culture. And I think the culture is very much a part of it, affecting how people are motivated for interventions, how they respond to things that are in the community. If most of the people in the community are heavy, then people's idea of what is the right body size may be different from a community where fewer people are on the heavy side. So the cultural factors are important, but they're far from the whole story. I want to say a little bit more about target marketing. Because for ethnic minority youth, there's like a double jeopardy. Youth are targeted, and as many of you probably know, trying to keep people from marketing unhealthy foods to children. In general, children and adolescents has been a big a big initiative within the childhood obesity prevention sphere. But youth are also targeted as part of their ethnic group. And what that means is that there's kind of a double whammy or a double dose of marketing that is coming into kids in ethnic communities. And so the likelihood of these messages advertising unhealthy foods and promoting them are drowning out any public health messages that might happen to go by is really quite high, and it's disproportionately high. Marketers have many techniques at their disposal, and just wanted to make sure that you're not only thinking about TV ads, but the kinds of marketing that drives people towards certain types of unhealthy products is of many different kinds. So I'm going to close up here with 2 slides, and this is taking you back to the settings perspective and showing that if you add to that a people perspective, you would think about what are we trying to do in these settings with people. We're trying to increase their access to healthy things, increase their resources for obtaining them, the receptivity to the interventions, and decrease the deterrence. And so on the last slide, I'll just put it up and you can think about it for a minute. We could come back to talking about this. I flipped the paradigm around to put what we're trying to actually do to help people in the middle and some of the settings and health and other types of interventions around the side. So I will stop there and turn this over to Tim Lobstein.
So this is Elaine Shiriki. Thank you so much. I'm just going to put up your contact information here for a minute. Just a reminder that if you have a question that you'd like to ask Shiriki, please use the chat box right there on the left side of your screen, and we'll address it after Tim's presentation. Shiriki, that was just wonderful, and as you said, if we want, we can come back to those last 2 slides that you flipped around. Well, thank you. That was terrific. Tim, I'm going to turn it over to you. Again, Tim is the Director of Policy at the World Obesity Federation, and he's going to discuss how policy and intervention design can impact inequity. And again, thanks so much for joining us from London.
Well, thank you, Elaine, and thank you for giving me a chance to join this very interesting webinar that NCCOR has put together, and I'm very pleased to be able to have a few minutes of your attention here. Okay, I'm not going to say a lot because Shiriki has said a huge amount here, and it's been very helpful to have her outline this whole area. I think I'm just going to sort of echo some of the themes she gave and give a slightly different cut from the European perspective. I'll just give a reminder that global trends are rising. I'll say something about what's been happening here in Europe. I'm talking, just in case you've joined us recently, I'm talking here from London, UK. And then I'll say something about the policy debate and different types of targeting or population-wide interventions that we need to think about and how we might sort of question ourselves about whether we're doing the right thing. And then finally, I'll just draw a few conclusions that we've sort of gathered from the international evidence, just to round off my part of this show. Okay, international trends, you won't be too surprised. They've been rising dramatically over the last 2 or 3 decades. In the U.S. is leading the pack here at the top line there. But as it eases off in the U.S., so it's been rising very dramatically in some developing economies like Mexico and Brazil, and in the Middle East, and even in China. The lowest line there is China, and there it's more or less tripled in the last 30 years. So we're seeing really dramatic changes going on all over the world. It's not just a U.S. problem. Okay, in Europe, there's been a very interesting study that used identical methodologies, similar sample sizes, and asking the same questions, looking at the educational status of the families, the parents, and asking what the child obesity prevalence rates are. And that was run in 7 countries. You can see the results there. And you'll see that virtually all countries, with the exception of Greece, that has an extraordinarily high prevalence of overweight children, but in all the other 7 countries, you get a very similar pattern, namely that children in lower educated families have a higher prevalence of obesity. Not surprising, you find that in the States as well. But one of the points I want to show here is that the difference is actually quite dramatically varied across different countries. So in Greece, as you see, there's hardly any difference between the 2 levels of education, but the rates are very high altogether. In Slovenia, there towards the right, there's a huge difference between the higher and lower educated families. And the other issue I want to bring out from this graph is how it varies from country to country. Even if you merge the 2 educational levels, you're getting very wide variation from, in the middle there, Netherlands and Norway, with remarkably low levels of child overweight and obesity, compared with Greece and perhaps Slovenia, and I can tell you also Italy has also got very high levels. So the variation across countries is large. The variation between education groups is also significant, and both of those feed into this issue about inequities and inequalities that we need to be looking at. Now, here's some very beautiful data from the UK. This, I'll just run you through this graph because it's not quite as simple as you might think. It runs from left to right, from the least deprived families through to the most deprived families. So we're talking about richer families, better educated, richer, fewer families on benefit and so on the left-hand side, and more families on benefit or claiming welfare, or having lower income or likely to be unemployed, more deprived on the right-hand side. And here you see this extraordinary, by deciles, extraordinarily uniform, consistent gradient across 10% deciles, all the way across for the younger children, aged 5 to 6, that's the red bars, and the older children, aged 10 to 11, the green bars. And one of the fascinating things about this survey is that it's not a sample survey. These are all children in England at that age group. And we've been running it now here for about 6 years in a row, so combining all that data, we've had a very large sample size, very consistent, and every year we're getting exactly the same pattern, extraordinarily uniform gradient. Now, I want to use that gradient, which is one of the most beautiful I've ever seen, to talk about interventions and different types of interventions. So if I go forward to the next slide, there's that gradient to remind us up in the left there. Now, if I represent that very sort of crudely as a blue line, the blue line on the graph below it, if that's the gradient at present, and then we introduce some intervention, perhaps an intervention like social marketing, sort of positive health messages on TV, or reducing gym membership, putting out vouchers for people to have better access to their local gym, or something like this, we might get a response that favors those who are least deprived, those who have the most resources, those who can afford to make changes or to subscribe to a gym, even at a reduced rate. So we might get a greater response on the left-hand side of the graph, reducing the obesity levels for them. But the gradient is actually steeper. So have we really achieved what we wanted to achieve? We've got greater inequity now. So that's not the sort of intervention that perhaps we should be looking at. Maybe we need a different type. Okay, so here's another one. This is where you really target those at the most deprived end, up on the right-hand side. You think of interventions perhaps free fruit and vegetables in low-income neighborhoods, I don't know. An intervention that is specifically targeted to a group in that most deprived group. And you get this response. You get an improvement, but you've still got, for most of the population, a serious gradient. So you haven't actually perhaps achieved the results that you wanted to achieve. So what do we want to achieve? Well, here on the left is a uniform improvement for everybody. Everybody improves by a similar amount, if you like, a perfect universal approach, which is great, and the prevalence of obesity nationally would go down, but you've still got that gradient. It hasn't really changed much. And there on the right is the sort of approach that might be what we're really looking for, which is called universal proportionality, or some people call it proportional universality. Namely, that you're doing a bit of targeting, but you're benefiting everybody. So you're finding an approach where everyone will gain, but particularly those who need to gain the most. And that, perhaps, is the sort of intervention we need. Let's think of an example. I've been looking at media exposure. As Shiriki mentioned, it's often the groups that are most at risk who are getting the most media exposure, and we have the same in the UK. So if we look at TV advertising on children, who's watching television? Well, on the left you have the higher income. They're watching less TV, children in high-income families, less TV than in the middle, or on the right, the low-income families. So exposure to commercials, particularly on commercial television, that's the red bars, is greatest amongst the lower-income groups. So if we think of an intervention that restricts that exposure by banning advertising of junk food on television, then that would sort of suit the purpose, wouldn't it? We would get exposure to ads, is greatest for lower socioeconomic groups. The intervention would apply to everybody. The implementation would be hopefully found everywhere, unless there's some problems coming in from outside by satellite channels or something like this. So the implementation should be pretty good, and that would give us what we want, a reduction in exposure applying to everybody, greatest amongst the higher risk groups, and that is a form of proportional universality. So that would be a pretty good measure. But let's look at something else. If we think about school interventions to teach healthy eating, then, well, low intakes of fruits and vegetables is indeed greatest for the lower income groups, so most deprived. The reach would be across, hopefully, the whole school and implemented by all the teachers. But the response, well, would it be so good? It might only be a short-term intervention. The take-home transfer is probably going to work better for the higher income families. The enthusiasm of the parents, the resources of the household, and so on, would all be better for high income families. So we're not necessarily getting the proportional, universal proportionalism we want. The effect is likely to be greater in the higher socioeconomic groups and might actually increase the gradient. So we have to think about checklists like these, and that's something we're trying to develop at the World Obesity Federation. Okay, I've got a couple more minutes, I hope, where I just want to run through a few of the conclusions we've got from previous work here in Europe. Firstly, I want to just remind ourselves that all income groups are stakeholders in this process. So we think about interventions. We want to make sure that we're bringing everyone with us. Are we consulting representatives from all stakeholders who are going to be the beneficiaries of the intervention? Are we making sure that they have a role in designing the intervention or some say in structuring that intervention or responding to it? Do they share the same priorities for health improvement? And that actually is quite a big one, because often in the more deprived communities, health isn't actually their greatest concern. They have other issues, usually to do with income, maybe housing, maybe crime, going on in their neighborhoods that they have a greater worry about, and their own personal health improvement or children's health improvement may not be their greatest priority. Working across sectors to improve health, well, that I'm sure is a familiar theme in the US as well as in Europe. Looking at the determinants, both the social determinants and any others, with a focus, I think, on commercial determinants. So my focus here in Europe has been largely on things like marketing of poor quality foods to children, the price of foods, taxation of perhaps soda taxes, as you've been thinking about in the US as well. So looking at these sorts of issues that will apply across groups but might affect some groups more than others would be very helpful. And lastly, I think we need to think about what are the sort of equitable opportunities for healthy choices. And we have a life course approach that the World Health Organization is always keen to recommend, where you look at both the adult, but the adult, of course, is a consequence of what happened in childhood, and the childhood is a consequence in part of what happened during pregnancy, when they were in the womb, and before that, the nutritional status of their mother. So you get back to adulthood, and there's a sort of circularity to this that we need to think, where in this circle do we intervene? Where is it most optimum to make the best changes? And there may be a good argument to say that it should happen during pregnancy. Nutritional status during pregnancy might be a huge determinant, certainly of childhood obesity, and even of adult health subsequently. But in order to intervene in pregnancy, you have to think about what is the quality of the nutritional status of the woman before she got pregnant, because that too has a bearing. So you have these issues. We also have to think about different socioeconomic groups and whether there are different underlying mechanisms. As I say, they have different concerns, they have different pressures on their lives, and may not respond in similar ways to a similar type of intervention. So we need to think quite carefully about how interventions, particularly if they're targeted ones, are designed. And lastly, just to think about how the people who operate the interventions, be they the health services or anyone else in sort of health promotion, about the prejudice and stigma that is surrounding particularly obesity issues and the problems that we have there, and how that is fed in turn by the media narratives about who is responsible for obesity and blaming the individual, which really is an issue that has to be tackled. So I think I've probably used up all my 10 minutes. Let me just check. Yep, I say goodbye at this point. So I'm here to answer questions, of course, but I'm going to hand back to Elaine now. Thank you.
Thank you so much, Tim. These two presentations fit together so beautifully. This has been wonderful. So let's get started with this one-on-one session of the webinar. Once again, I'm Elaine Arkin with NCCOR's Coordinating Center, and I'll help moderate this discussion. And for this session, we have both Shiriki and Tim available to answer your questions. And again, you can use the chat box on the left of your screen. We have a couple of questions from the audience already, and we have one to start out with Shiriki. This first question is for you. You've noted that we've traditionally been looking at the issues through a settings perspective. And how do we now move to incorporating that people perspective?
Thanks, Elaine. So that's a great question to follow up on some of the last points that I was trying to make. So I think when it says to traditionally here, it refers to the sort of recent past when we realized that we couldn't keep addressing obesity with only individual counseling, individual behavior change approaches, but had to add environmental change approaches. Perhaps looking at settings was somewhat of an overcorrection in the sense that it took the focus off of the individuals in the settings maybe too much. So I'm trying to add that back, not just for each specific individual, but to think about groups of people in that setting who may need something more, kind of have a checklist. Do people need more resources in order to be able to take advantage of this intervention? Are they likely to have different receptivity? So people in environments where they're being bombarded with more messages than other people in the setting, like school children, may be less receptive because perhaps they've been persuaded by some of the messages that what's being told to them in school isn't necessarily going to reach them. Now, it could also work the other way. It could be that some things you do in a setting are going to reach the high-risk groups more, and you could also identify that if you went through the thought exercise of looking at resources, access, receptivity, deterrence for specific groups in a setting.
That's great, and that also fits in with the kinds of checklists that Tim was suggesting as well. So that's terrific. Tim, did you have anything you wanted to comment on that question before we move for you?
Well, I was only going to say that in Europe we've had a huge focus on sort of school settings, and my argument about that has been that schools are great, but that seems to be the only evidence base we have. So if you base yourself on sort of evidence-based interventions, schools are where all the trials are done. So schools end up as being the settings that people then go into. And I'm worried that we don't have the evidence for things like changing community shops, changing prices in the shops, restricting different types of marketing, and we simply don't have that evidence. So the settings of schools, there's a sort of bias in the literature that has always focused on schools. So that's just a sort of footnote to the work that Shiriki has referred to.
And Shiriki, how was that handled with the IOM panel?
Well, the IOM report, I think we're working on that now through the IOM's Obesity Roundtable, because in the report, we were so limited we were trying to get evidence-based recommendations, and we didn't have enough evidence that specifically told us how it would work in high-risk groups. So the recommendations are very general, and we have yet to really understand how some of those recommendations apply to high-risk subgroups. I think if you take a supermarket, we've done supermarket interventions, and we put that supermarket there, but people are going to experience that supermarket very differently once they go in. If they're budget conscious, they may go for foods that are on sale. If we haven't changed the pattern of what's on sale, then the supermarket isn't going to work to have them bring a healthier market basket at home.
Okay, so we definitely have a research agenda here, too. So, Tim, I'm going to turn this over to you now with a question here on the screen. Does Europe have a similar issue with racial and ethnic group differences within areas seeing declines in childhood obesity as we've seen in the U.S.?
The answer is probably. Because we certainly have wide differences in obesity prevalence across the different racial and ethnic groups, just as you have. And we have pockets of high levels of prevalence particularly amongst recent immigrant groups in sort of urban settings here in Europe, first and second generation migrant groups. And of course, there's always a complicated mix of both socioeconomic and social deprivation and educational level and cultural norms and practices with the ethnic mix, which makes it hard to state what is a true sort of ethnic community difference and what is largely a socially determined effect. So I can't really answer the question about differential trends, as we don't have good enough trend statistics for ethnic groups, but it is well accepted that the signs of a falling incidence of obesity prevalence are seen in the better off and more educated families, and little sign of improvement in the lower income, the poorly educated families. And I'd expect the same for minority groups, which have so far been showing higher prevalence groups. And I might add that, like the USA, we have minority groups who actually show very low levels of obesity prevalence, as I think you do too, quite small minority groups. But, for example, here, the sort of Far Eastern immigrant groups from China, Korea, Japan, for example, tend to show remarkably low levels of prevalence, much lower than white native Europeans.
Thank you, Tim. And Shiriki, I'm going to turn it back to you with a question from Kim in our audience. And she asks, the cross-sectional data is very compelling, but I was wondering if there's any cohort data demonstrating trends in childhood obesity, and if they're similar or different.
I haven't seen cohort data that allow you to compare what's going on in the population in this way. I think we're relying on cross-sectional data, but have to keep in mind that the younger cohorts in the cross-sectional data are a feeder system. So when we look at what's happening in 2 to 5-year-olds now, and then we look a few years forward at what's happening to 6 to 11-year-old children, we can see maybe what's coming in those different age groups. And so we can take a longitudinal perspective, but by looking at these slices of what's happening to new kids coming into the world, and how their rates are going, and then how that feeds into prevalence trends going at the higher ages.
All right. Well, thank you. Great answer. And for Tim, from Christina. Christina asks, I was hoping that Tim could comment on why the SES obesity gap in England seemed to be wider than their European counterparts.
Okay, I'm not sure that they are. I think, as I showed in one of my slides, the variation at least for education of parents, the gap between high and low was quite wide in some countries and not so wide in others, and we didn't even have the UK on that graph. But I think one of the reasons why that UK data is so smooth and beautiful is because it includes all children, whereas nearly all the other data you'll get are samples. And usually with samples, you do get little bits of bias creeping in where some of the children don't want to be measured, or some of the parents don't really want them to be measured. So if you don't have complete measurement, you may well get a reduction of the sort of effects that you would be looking for. Not necessarily, it depends how, whether there's a bias between high or lower educated in how they respond to being surveyed. But the beauty of the UK data is that it is about 97% of the children of that age group. But I don't think that explains the gap. I'm not sure if I can explain the gap. I think that there are cross-cutting factors here. For example, just the overall level of inequality of income in a country has a determining factor. Countries with highest income inequalities, income disparities, tend to have higher rates of poor health, including higher rates of obesity, diabetes, and so on. Fascinating. In fact, I think we can show the same for U.S. states, that those with the greatest disparities of income also have higher health levels, health problem levels. So, I mean, there's so many cross-cutting factors here. As I showed in the graph, Norway versus Greece has hugely different levels of child obesity. So what's going on there? That sort of level of disparity is extraordinary and well worth looking at, because it must indicate some very significant drivers. And I think you'd probably say the same for states in America. Why is Colorado showing much lower, about hardly more than half the prevalence levels for obesity than Mississippi or West Virginia? Why have you got these extraordinary differences, and what does it tell us about the drivers of obesity in society?
I think that's a great question to end on, Tim, for us all to be asking ourselves and asking in the research that we are undertaking. So I hate to cut off this conversation, because there's some really great questions coming in right now, and thank you all for contributing them. We're going to be keeping track of those questions, so keep writing them in. Because we're going to run out of time here, we'll be posting answers to your questions on the NCCOR website following today's webinar. And so thanks. Keep them coming if you have additional questions. Now, what's next? There's a lot of interest in this topic, and it would be great if we talked just briefly about what's coming up next for NCCOR when it comes to exploring research and efforts in this area. There's one exciting activity that we wanted to tell you all about on this call, and that's NCCOR's Childhood Obesity Declines Project. So Childhood Obesity Declines is an NCCOR project funded by the Robert Wood Johnson Foundation and conducted by ICF International. As you've learned today, cities, counties, and states around the country have been increasingly reporting declines in childhood obesity over the past few years, and reports have shown that progress is not being experienced equitably. Those at highest risk of childhood obesity typically have been experiencing the least progress. Because little is known about what might be driving those declines, as we've heard today from our speakers, and why disparities seem to persist despite overall declines, this study is designed to understand what kind of initiatives, such as strategies, campaigns, programs, policies, again, some examples we've heard today, that were implemented in each of these four communities, which of these reported declines, and also we want to get a sense from key stakeholders within the communities being studied about what might be the key contributors to the declines and the factors that might be facilitating a reduction in disparities. So as you can see on the screen, this is in Anchorage, New York, Granville County, North Carolina, and Philadelphia, Pennsylvania. So where are we? There's extensive data collected, including a scan of local, state, and federal policies that were in place in each community, a comprehensive inventory of strategies that were being implemented across four key settings: schools, early childhood education, healthcare, and in the broader community, and in-depth interviews with policy and program developers and implementers, community members, and researchers, a wide a number of kinds of people during site visits and follow-up phone calls. So the goal of the interviews is to better understand how initiatives are developed and implemented, why they're selected, how they're evaluated, monitored, and what factors facilitate or impede the implementation of interventions. So the interviews enable researchers to dig deeper into stakeholders' perceptions for why their community did or did not experience reductions in obesity among communities of color. Why did some communities really target communities of the greatest need with their efforts? Or were the strategies more universal? We've heard about both of those kinds of strategies today. So right now, the current status, the team is in the process of analyzing all of the data that's been collected, and we anticipate that a cross-site report synthesizing this information and identifying key similarities and differences will be released early next year. So this report might be supplemented. We hope it will be supplemented by a webinar, another one of these Connect and Explore webinars, that would also be targeted towards community stakeholders like policymakers and practitioners. There will also be a manuscript submitted for peer-reviewed publication. So for more about this Childhood Obesity Declines project and its status and when you can expect a webinar, please visit www.NCCOR.org. So, if you have any questions about NCCOR or other upcoming activities, including webinars, please email the NCCOR Coordinating Center at ncor@fhi360.org. Now, we're just about out of time. But I do want to note that all Connect and Explore webinars are archived for future viewing. To access the webinars, go to the Resources tab on the NCCOR webpage, homepage, and then go to NCCOR Resources, and through the Resources, click on Webinars. And I urge you to share information about today's interviews with presentations with Shiriki and Tim with your peers. It was a great session and a lot of questions for us all to be thinking about in designing the most appropriate interventions to reduce those disparities in obesity. You can also stay connected to us at NCCOR by following NCCOR on Twitter and LinkedIn and visiting our blog and signing up for our monthly e-newsletter. Again, visit www.ncor.org to engage with the collaborative. Thank you all for joining us today, and thank you all for your great questions. You will be finding more answers on our website.